So this is it. This is the last panel discussion of this two-day meeting, because as you know, we're going to switch gears a little bit, and you know, we'll hear from Laura shortly about how we're going to switch gears for the afternoon session. And as I mentioned earlier this morning, our goal really is to really focus on solutions. But before we get to solutions, as we were planning this workshop, we kind of said at some point, you know, we kind of had feds interspersed throughout this whole time period. But we realized that federal leadership in this realm is not to be disregarded. We talked yesterday about how maybe there has been a focus of change in the federal system. And as a former Fed, I'm actually the freest individual here on this stage. But having spent 28 years in the federal system, and here I talk about the government functioning system, not the federal system, i.e. the prison system, what I want to focus on is, you know, we kind of talked about this yesterday, was, you know, to some extent, maybe in the old days we used to say, wow, the feds, we're in charge. And there used to be this feeling as if we come on board and it's, okay, the feds are here, everybody move away because we can do this. And I would say, certainly in my career path, once we started hitting sort of a time period, and perhaps it was exemplified best during Hurricane Katrina, where we realize, you know, we just can't handle it. When it gets really big, it's not just our responsibility anymore. And maybe there was an aha moment, which is there is shared responsibility here. There is maybe a newfound approach to shared governance in all this. But at the same time, you know, we talk about medical countermeasures. We talk about this aspiration of getting to this national capability to monitor and assess medical countermeasures. It's going to some extent start here, right? Start amongst the federal system to provide that leadership, to provide that direction, but now hopefully with a new mindset, which is we're here to partner as feds. And who I have here on the panel, I'll start. Stacey Arnesen is the Chief Disaster Information Management Research Center, Specialized Information Services, the National Library of Medicine at the NIH. Stacey, thank you so much for being here. Greg Burrell is the Director of the Division of the Strategic National Stockpile, CDC. Thank you, Greg, for being part of this. Redonna Chandler is the Deputy Director, Division of Clinical Innovation at the National Center for Advancing Translational Sciences at the NIH. Thank you as well for being here. John Fleming is the Deputy Assistant Secretary for Health Technology Reform in the Office of the National Coordinator for Health Information Technology. Thank you. Joe Larson, I was going to call him Joseph, but he says, oh, that only happens where people are yelling at him. So if you do, during the question and answer period, are angry about something that Bart is doing, call him Joseph, just to set him on edge. Joe Larson is Deputy Director, Division of Cbrn Medical Countermeasures at the Biomedical Advanced Research and Development Authority. Thank you, Joe, for being here. And then someone we've heard from before yesterday, and that's Carmen Marr. Rear Admiral Carmen Marr. Notice I did it correctly, because when they used to call me Rear Admiral Boris Lushniak, they used to always put the emphasis on the word rear, which I was always very sensitive. Notice how I toned it down. Rear Admiral Carmen Marr, who's the Acting Assistant Commissioner for Counterterrorism Policy at the FDA. And thank you all for joining us. You know, we've heard a lot over the last day and a half right now. And some of you have been privy to these discussions. Others are just sort of playing catch-up at this point. You know, we talked about the gaps, we talked about the challenges that exist out there, and the opportunities. And again, with that specific focus on monitoring and assessing medical countermeasure use in the midst of these emergencies. You know, we've been in the process, and again, the culmination, I hope, is going to be over the next few hours. So, starting with Carmen and working around, right, what I'd like you to do is sort of provide things that you've observed over the last day and a half. If you've not been here, that's fine, you can pass. But Carmen, what have you observed at the workshop so far? You know, what's come to you right now as a single big thought, as a double big thought, no more than 3 things that you've walked away with thus far?
So first of all, I want to thank everybody for participating and that's not one of my three things. Seriously, I am so grateful that you all have come here to share your thoughts and to help us with this. The first thought that comes to my mind is that medical countermeasure monitoring and assessment, and I said this just a little while ago, is a really, really little fish in the big public health pond. And public health emergencies is maybe a little bit bigger. We're a piece under the public health emergency conundrum. And what I'm hearing, in light of all the different things, we started out looking at what we've done, where we've been, what are new technologies, and we've bucketed these 4 areas. And what strikes me is that we've bucketed the right 4 areas, I think, in terms of field operations, in terms of ConOps and electronic health records and big data and clinical trial networks. And there's a lot going on within the different buckets already. And there are a lot of solutions to be had if we can further socialize this tiny medical countermeasure assessment piece into the conversations, discussions, the development of the stuff within these different buckets, and link to what's already being done. And so to me, that's the biggest takeaway. There's a lot more refinement of the conversation that needs to happen, that the workshop has provided clarity for me on where we need to go with those conversations. There's a lot of opportunity that we can tap into, and there's a lot of socializing of our problem that still needs to happen so that we can continue to talk across the diverse stakeholders in this.
So, as we do this, and this isn't single speeches, so we're going to do this in sort of the conversational format. So do you have hope?
Absolutely.
After this? I talked a little bit about the innate optimism that happens in public health. What's your feeling regarding, can we get to a place that's there's a better place out there? Can we get there?
I absolutely have hope. I think, there's some of us that have been talking about the medical countermeasure assessment, monitoring and assessment piece for a long time. And there's a group that's been talking amongst ourselves within the federal government. We socialized a little bit of it. And this is our real first foray into socializing it on a grander scale. And so just in the discussions that we've had today with the participants that have joined us over the last 2 days, I have a lot of hope. I have a lot of excitement, and I have a lot of enthusiasm, and I have a lot of notes of little nuggets, pieces, things that have been validated in terms of the assumptions we've already made with regard to this space. Thoughts about where our assumptions may have been incorrect and where we need to correct a little bit of our assumptions. And then areas where we thought we had clarity that still need additional clarity, and areas that I hadn't even thought about that we need to be thinking about in terms of the medical countermeasure monitoring and assessment during a public health emergency. And so I am extremely enthusiastic and hopeful, looking forward, more so than when I walked in on Monday morning or Tuesday morning. So.
Great, thank you. Redonna, any reflections, anything from your perspective or your viewpoint, your piece of the action here?
So I wasn't here yesterday, but I did look at the executive summary, and as I was walking around during the break, I was overhearing a few conversations. At NCATS, we have this tremendous resource that fits into your 4th bucket around clinical networks. And a part of our mission is all about creating innovations that help research of all different types. And we have a real sense of urgency at NCATS. We want to be able to do things that are unique, that are innovative, that are necessary, but that speed up the process of clinical research and capturing data. And some of the things that we currently have built, I think, can be very valuable for the types of data that would be necessary. So for example, we have a large clinical network infrastructure, the Clinical and Translational Science Award Program. For people that aren't familiar with the CTSA program, It's a network of over 50 academic medical centers that sit all across the country. And there are certain types of innovations that are intended to take those different organizations that may have traditionally been siloed and may have, you know, Harvard does great work, but maybe it was just local, or Mayo Clinic does great work, but perhaps their work was just local, or the UCLA Medical Center System, they do great work, and they had come up with some regional collaborations. But we have really embedded infrastructure that is led out of NCATS within all of these different academic medical centers to create platforms and personnel that are available to be able to come together quickly and work together quickly as a clinical research enterprise. We have hired someone within the last year and a half in the area of informatics, and so we are very much working on trying to create interoperable data warehouses across all of those different medical centers that could be invaluable for many different types of research questions and endeavors. And embedded into that, a rapid way of being able to recruit people into research. But then there's some other things that we've done that people may not be aware of. So for example, all of these different academic medical centers have signed on to a treaty around IRBs, where they've all agreed that they'll see to one another in a very rapid fashion, and we in fact are working through, now that they've all signed on how that would happen and how that could happen quickly. This was actually tested in a pilot study because Harvard was one of the very first CTSA programs that developed and signed other hospitals in their regional area onto this single IRB treaty and looked at how to seed review. And during the terrorist attack in Boston, for the Boston Marathon, there was a desire to very quickly get into the field with some research because there are certain research questions that couldn't be answered except under these circumstances. And there was a particular group of investigators that were interested in looking at hearing impairment at the exact site of the blast and then in geographical circles around the blast and hearing repair, something that can't normally be done. And so they took what is an ethical review process that can take months to years and shortened it to days. And we're able to move very quickly into the field. So we have not only this network, but a certain level of expertise that I think could really be beneficial and helpful. And as you're talking about local versus national, as someone who was deployed to New Orleans right after the hurricane, I'm aware of the tension that exists between we're the government versus there are people there that really understand the local needs in a way that we can't. That's one of the best things I think about the CTSA network, is that we fund them as local centers of excellence to really know the resources that they have available, to really know their institutions, to really know the service delivery system in their particular area and the needs of their patient population and what makes them unique. But then we also have worked very hard across the last few years to set this network capacity on top of it so then they can also come together and function as a national network.
And so you provided the Boston bombing as an example of a system that can be put into emergency mode rather quickly, right? The other question that I have, is the sense is, have you been engaged in these discussions regarding medical countermeasures, right? We talk about this session being a collective action. Have the right people been talking with you? Have you been talking with the right people? Is there a connection right now, or is this something that we need to evolve further regarding the use of medical countermeasures and monitoring and assessing them?
So I will say for myself, I have been in this position at NCATS for a year. So I don't have a long history there at the organization to have been involved in a lot of discussions. I think that there is definitely space for having some ongoing interaction, for seeing what capacity we may have across NCATS and everything that we do, whether it's our intramural program and lab, and where there's a lot of expertise and speed for doing things like looking at repurposing of existing drugs or screening known compounds. And they've been involved in a lot of different health crises and issues, to the CTSA program. So I think there's always room for more collaboration and engagement, and I think we can definitely talk about how to do that moving forward.
Great, and we sort of want to obviously tap into that. I mean, you know, we kind of look at this panel of those, you know, who are already involved, who obviously need to stay involved. Those who need to be involved, you will, by the end of the session, get deputized, you know, to be part of the medical countermeasure world. And maybe that's one of our solutions, is that, you know, some of these discussions amongst even our federal family, you know, doesn't take place. We all go back to our day jobs. And where your day job is medical countermeasure, then you go back and you sometimes, knowing, you know, Carmen's position and her team's position, you sometimes feel a little bit alone. You know, this whole idea of connecting ourselves and aspiring this collective action is critical. John, what do you think about this?
Well, I was appointed less than 90 days ago to be DAS of
You know,
HHS.
you look so fresh and alive and not at all weathered by the storm.
Right.
But so welcome to the...
Well, thank you.
And what did you do before that?
Well, I was 8 years in Congress, and I represented a district in a state, Louisiana, that knows something about natural disasters, and really spent a lot of time with that. Before that, I was a private practice family physician, and before that, I was a Navy family practice physician who knows what it is to deliver babies in the middle of a hurricane on the island of Guam. So I've seen my share of emergencies. Just calling on some personal experiences in Congress, remember, I think it was last year, perhaps a year ago to be exact, when we had historic flooding in the Baton Rouge area. The 1,000-year flood level was actually achieved by that. And one of the things that we learned by that was we have such wonderful off-the-shelf technologies that overnight, literally overnight, a Cajun Navy was stood up that were the first responders that saved people from their homes, that took care of medical emergencies and so forth. And then also we go back to Katrina, which has already been mentioned a number of times. Recall that the Charity Hospital there had complete flooding of their chart room, which happened to be in the basement. So there was no access to medical records. So the space I work in now is something that's very near and dear to me as a physician who adopted electronic health records over 20 years ago. And that is the need for information transport or transfer, particularly in emergencies. And that's one of the spaces we've been working at. One of the things that we learned out of Katrina was the need to stand up a system, which we now have is called PULSE, which the acronym is Patient Unified Lookup System for Emergencies. And what it does is provide for connectivity with 40 health information exchanges. And what's important about that is understand that healthcare data from an electronic perspective falls into two categories. One is structured data, that is a information set, a numeric set that goes from point A to point B. And that might be a list of problems or diagnoses or a list of medications, a list of treatments, things that can be quickly delivered. And the interoperability is a lot easier from the standpoint of not having to transport information on imaging and free text and all of that. So setting up that connectivity is hugely important. For instance, what about an outbreak of some type of infectious disease epidemic? Who has the immunizations? Who has the record on immunizations? How do we know who have had that and who needs that? These are all things that we're building as we speak. We really have not achieved what we need to do. But the point being that we're in the electronic age. Healthcare is lagging behind the rest of the world when it comes to that, and for probably some good reasons having to do with the complexity of all of that. But that's really what we're working on, is how we can make medical records, first of all, easier to create for the providers, and second of all, interoperable. That is where we can send information from point A to point B in the completeness we need. And when it comes to emergencies, we don't need all the records. What we mainly need is the structured data, the list of things that are so important. Again, back to Katrina. What we saw was a disbursement of the residents of nursing homes, for instance, and assisted living. They were sent, to Texas and to Mississippi and places like that. And the people, the nurses and doctors receiving them, had no idea what medication or diagnoses they had. And frankly, we had some deaths involved with heat exposure and those sorts of things. So I think that going forward, we're much better positioned. We've got the backbone and communication. But we also have to leverage our private partners who are out there ready to help when called upon, and utilizing the kind of technologies that are available today in the private sector. So I think that gives you a good idea, but we have to keep in mind privacy and security, big issues in the healthcare arena, and we're working towards solutions with that. But it requires being very vigilant on policy and also on standards to be sure that records can't be hacked or misused in some way. So hopefully that gives you an evolution of what we've seen coming out of natural disasters and how healthcare information is so important to exchange.
And then looking at something that's come up several times in our discussions, and it's the F word, it's funding. And you have that interesting perspective, which is on the one hand being in the halls of Congress and
right.
looking at funding from a different angle,
Yes.
and now being at ONC on the receiving side.
Right.
Is there interest from your sort of sense of what goes on in the legislative branch to actually look at funding aspects? And I'm not saying, is it going to be out there? We know we're in difficult times, but how much of a priority is this?
Well, funding is obviously very important, and understand that we have more of a coordination function than we do a deliverable function. For instance, we actually sent over $30 billion out the door to help encourage providers to adopt electronic health records. Money didn't come from our budget, it came from CMS. So it was our job to coordinate this. Now we're coordinating such things as standards, quality measurement, measurement of interoperability and how we achieve that, overcoming information blocking. And to understand that, you have to understand that when it comes to transport of information, it goes from deliberate information blocking that may occur among vendors or perhaps even from healthcare providers in a continuum across where you get to complete and full interoperability. And right now, we fall in different places at different times and in different ways throughout that. And we're trying to improve that without giving up privacy and security. But on the funding side of that, we're now working on implementing rules and regulations for the 21st Century Cures Act, which passed out of legislation last year. I voted for it. But there obviously becomes funding concerns to be sure we can carry out those requirements.
Great, thank you, John. Stacey, from the National Library of Medicine, you got to, in your title, the word disaster, the word information, the word management, the word research, and then it becomes a center. What's your perspective on all this?
Thank you. Unfortunately, I wasn't here yesterday due to my son's high school graduation.
Well, congratulations.
Thank you. But I did get notes from Alexa and from a colleague who was here, so I will speak even though I wasn't here. And,
so you did the same thing I did last night. You said, Alexa, notes.
Yeah. And there was one thing that really stood
Sorry, Alexa. It's a running joke. Where is she?
But there was a word that stood out there, and a comment, and that was the need for unicorn. And it talked about data scientists who also have experience as healthcare providers. So I think I'm here today to talk about perhaps the unicorn is real, and the unicorn might be NLM, the National Library of Medicine. Probably people are thinking, what is someone from the National Library of Medicine doing here? Well, we do have...
Well, when you walked in, I thought it was that overdue book
Yeah,
from several
right.
years ago that I have in my possession, so.
We do have a disaster information management research center, but really, why do we do that? What does a library have to do with disasters? Well, a couple of the major issues in disasters that we hear over and over again are information and communication. Well, that's what libraries do, is information and communication. What we've heard more recently as another issue isn't just information, it's data. And I think that's what the last couple of days we've talked a lot about, data for medical countermeasures. Well, the National Library of Medicine and other libraries also do data. And in fact, the National Library of Medicine, our new director, Dr. Patty Brennan, has been named the acting associate director for data science at NIH. So data science is going to be big in NLM's new strategic plan that we're working on right now. So we're moving into our third century of being around. We have gone from sort of the collecting the information, those books and overdue books, to organizing and indexing the information. And now we're moving into what can we do with the data and how data can go from just data to discovery. So a lot of issues about data sharing come up and talked about, open data, data tools for analysis, for data science. So I think NLM actually has a lot that we can offer in this area. And I think some of the things to look at are what, actually it was the Harvard Humanitarian Initiative who described the phrase data preparedness. And how can you have tools that are ready to be used in an operational context, an operational response, that are ready to go for data collection and data analysis. And I think at the National Library of Medicine we can help in many ways.
And I'll pose a similar question like I did with Redonna, is have you been engaged at this point? You know, have you been embraced by this medical countermeasure community, or is this now something that needs to further evolve for you?
Well, I think it always needs to further evolve. We have been engaged in the sense that we work with ASPR on REM, the Radiation Emergency Medical Management, and CHEM, Chemical Hazards Emergency Medical Management tools, which of course provide information on medical countermeasures. So we have been involved in some regards, but there are other areas that we haven't been involved in because as I hear many times from people, oh yeah, we forget about you, or yeah, we didn't think about the National Library of Medicine. So sometimes we're not brought in, sometimes we're brought in, often a little bit at the, you know, at things have moved along, and they say, oh yeah, let's talk to NLM about that. But one of the things about libraries is that who doesn't like a library? You know, everybody likes libraries. They're a good thing. People don't think of libraries as government, and sometimes that's a good thing too, because and libraries are considered a very trusted source. So from a variety of angles, I think NLM and other libraries, because we have a pretty broad network across the U.S. and we work internationally, that we can help with medical countermeasures and other areas in disasters and public health emergencies.
Great. And have you met John Fleming before?
No, just
and
today.
that, again, that is our success story, because that, ladies and gentlemen, is collective action. We are done. Joseph Larson.
Yes.
So you're the BARDA guy.
Yeah.
Okay? And when you look at, you know, the BARDA thing, right? I mean, you're out there, you're looking at medical countermeasures, you're looking at, you know, inspiring research and development and, you know, and perhaps throwing out a little bit of those limited funds towards the purchase and acquisition of those. What are you looking for? What are you looking for in the big picture in terms of looking at these countermeasures that you are purchasing, that you are in charge of, that you are out there inspiring the innovation of? And yet, at the end of the day, we all admit we're quite not there in terms of even determining if they work if we were to use them. What's your perspective?
Well, first I would say that the FDA did approve these products based on safety and efficacy under a provision, the animal rule. So to say that we don't know if they don't work, I mean, I don't know. We always are looking for filling preparedness gaps and making investments that are going to be not just incremental, but, you know, transformative in our capacity to respond. My thoughts on the last couple of days, I think certainly getting this data is of value. And I don't think there's any question of that. This is, health IT and HIPAA is not a world I live in. But from my kind of rudimentary observations, I would say that this seems to be not a technological problem, but more of a policy one. I think industry does need to be involved. These sponsors need to be involved, and I was glad to see there's 2 sponsors of products that have also been approved that are here, and one of them was on the panel yesterday. Because I think they can provide real, tangible feedback on what it's like to have to design these kind of studies for these phase 4 requirements that they're facing. I think we need to get information on what type of information is absolutely necessary that we need and what would be nice to have. I think we need to define who's accountable. I think there needs to be one agency that's going to lead this and be responsible for collecting this information.
And who should that be?
To be honest, I don't think it's BARDA. I think it's either CDC or FDA, but I don't want to, I'll let that be determined.
Okay, well, let's table that question because
Please.
Yeah.
I also think that we need to determine who's going to pay for this and the cost for this.
And who should pay for it?
Well, right now.
Okay, let's table that question.
I say right now, for example, we are funded a expanded access protocol for ZMAP to have access to collect data in the 2 countries that were affected in West Africa and 11 sites domestically here in the United States. And even just capping that at a max of 35 potential patients, we still have to cut a check for $3 million a year to have that capability, even if we're not using it. And so start multiplying that by 10 or 15 different medical countermeasures, and it's not an insignificant investment to have this at ready in the event of an emergency. I also think we could start where we already are collecting data on medical countermeasure effectiveness, and I think about HBAT and the routine cases of botulism that occur. And could we think about piloting one of these systems around that, because we know botulism is going to continue to occur naturally, and I think we have a countermeasure that's approved, and so maybe that could be placed in a paradigm for further study. And then I think we also need to overlay this with the sustainability of the enterprise. We're already having a lot of challenges sustaining the companies and sustaining the investments that we've made over time, and I think that needs to be considered as an overall component of the discussion as well.
And where do the companies, I mean, you're interacting with companies, again, without naming names, are the companies interested in terms of this next phase, right? Which is, not necessarily just the last mile, but what's beyond that last mile, i.e. Monitoring and assessing of their products.
I think it's important to have them at the table in the discussion when we're designing this so that we can get them on board, but I think it's also part of ensuring that there's continued re-procurements of their product in the future, which is ultimately driving their commercial returns, which is going to drive their bottom line. And I think that's how you get them at the table and interested in continuing to do this.
Great, thank you, Joe.
Yeah.
Notice I switched.
I appreciate
the whole
that.
thing. I went from anger at you to basically now we're friends. Nice.
All right. Deal.
So first, a word from our sponsors, and we'll be back in a minute to hear from Greg Burrell. Okay, well, now we pretend we're on TV and stuff. So we do this. The congressman has probably been involved in this stuff before, so now we're in the green room and all that. Take your sip and all that. So everybody's okay up here? Okay. Audience is you're all laughing at the right parts, because we don't have to do the camera laughter part. Okay, count me down, 5, 4. As you can see, I live in the world of fantasy all the time. So, this doesn't work unless I think that we're actually being broadcast to 1 million households on the MCM network. Medical countermeasures 24/7. That's what you should invest in, right? There's a lot of room out on the cable world. So Greg Burrell, Greg and I go back, I don't know, how long, Greg?
10,
Years.
11, something, long time.
Yeah. So
I didn't used to be this great.
I was still in uniform, and he wasn't this great. So for a long time, and we've been friends and colleagues in this endeavor. So Greg, you're in charge of this strategic national stockpile, right? You're in charge of making sure that the stuff that FDA licenses and approves, right, that's paid for previously by people like you, John, that is now put in and sort of work through the BARDA mechanisms and then given to you. What's SNS's responsibility in all this, right? Because we know that you want to get it out, and we've heard from the locals and the state individuals out there. We know that they get the stuff, and you put responsibility on them to get it out to the people. Why are you sitting here?
Because y'all said. So, I think there are a lot of things about this whole discussion that really captivate me. And so when we think about just what we're talking about, monitoring and assessing medical countermeasure use, and we tend to go trundling down the road very quickly to what's the safety, what's the efficacy, what's the adverse events, and all this kind of thing. But there is a whole spectrum of data and a whole spectrum of information that we need throughout a response to be able to craft that response to meet the need that we're trying to address, and then rapidly shift if something tells us we've got to make a change. So when I think about data and information needs around medical countermeasure use, I think there's a whole piece of this that isn't a small fish at all, Carmen. It's a big fish. And I think it's a big fish not only for the SNS, but for the states and the localities that we're trying to support. So I think in terms of when we did the distribution of antivirals during the H1N1 event in 2009, we sent them out, we got them to the states. We didn't have real rapid feedback on what was happening with those things, right? So that's part of that use question. So I wonder where we can get information on that use. I see two basically categories of countermeasures we have to deal with. Those that we're going to give people in a non-medical setting, and those that are going to be administered in a more traditional medical setting. And I think for that second category, there are a variety of systems. They may not collect all the data we want. They may not collect the right data we want. They may not get it back to us fast enough, but we need to look at that. It's the piece that we're doing in that non-medical setting where I think there is a huge dearth of any kind of data. And so where can we find information? And it may be some of these real non-traditional places. So what can we mine Twitter for? What can we mine Facebook for? What can we see that's out there that suggests people have some confidence, so they're going to go get the medicine, or if it's delivered to them, they're going to use it appropriately. Over time, are they complying with what we've asked them to do with that? So maybe we don't get people into that treatment piece where we have to figure out were the treatment materials safe and effective for use. There are a lot of questions like that that are instant. And so my interest here is how can we look at things that already exist that might answer some of those instant questions that would suggest to us that our response is doing what we want it to do, or that we need to adjust it in some way immediately, or we're going to not be successful. So I think that's one piece of that. And I think another piece from that collaborative, how can we do something different? How many failures at building systems in government have we seen? And having grown up to a certain extent in that IT side of the world way back, saw a lot of it. What can we do collaboratively with the states and locals, and what can we do collaboratively with industry to come up with something that simple, easy to use, self-reportable. Maybe there's an app that ties into what New York State is doing to collect advance information that then they could walk out the door of a point of dispensing, or having received medical countermeasures at their home, they could, post having that happen, say, I got it, I took it, I was okay. The second day, I got it, I took it. The third day, I'm not interested in this anymore. These are things that would change the way we want to think about a response. So, I think that there may be an opportunity for us to work with our state and local partners, with our industry partners, so that we can all see instantaneously that same information. Maybe if we could share the development or creation of some kind of an app. Maybe we could share the development or creation of just some essential elements of information so that we ask questions or craft questions in advance because we know what we need to know. We don't know everything we need to know, but there's a big block of what we need to know. We could sit down right here and brainstorm, and we could all put it up on the screen, and we'd walk away and say, yeah, that's it. We need to do that now. We don't need to wait until the day an event starts to start going, what do we need to ask? Because that way we can meet those data people in the middle and say, this is what we think we need to know. Do you think that makes sense? And is there something else you think you could tell us that might be of interest to us? So I think these things would be interesting to continue to pursue.
And do you think that, and I kind of divide this group into almost, there's two groups here. One are the people who need to get that data, and therein lies FDA wants something, CDC wants something, and BARDA wants something. The rest are people who are trying to build in interoperability, who are offering perhaps networks to feed into this. So it's a 3 and 3 division on here. Is what you're looking for and what you're looking for and what you're looking for the same? We had a discussion yesterday about what data are we looking for. And I think it's a great point, which is ultimately, what the heck is the question, right? What do you want?
Exactly.
Greg Burrell, what the heck do you want?
I want to know how things are going. Are people making use of what we're giving them, and is it having the immediate desired effect? That's what I need.
And what
to
do you
know.
want, Carmen?
I want to know if the countermeasures are performing as we expect them to perform, because it's true, there are countermeasures that are approved, that are going to be used, that are in the stockpile, that have limited human effectiveness data when they went in. And the only time we're going to be able to use that countermeasure in the affected population is during the emergency. And I need to know if what we are assuming and what we extrapolated from those animal studies is actually the way the countermeasure is performing, so that then I can feed that information back to the state and locals, back to the clinicians, back to Greg, to say, hey, stop the deployment of that countermeasure right now. I can feed it to the aspects, that would not be my decision. But you kind of get the gist of what, from an FDA perspective, and then the tiers of the types of data for the types of decision that need to be made, including the level of data that will enable regulatory decision making, which is one, the FDA piece of this, and getting to a place better than where we are right now. And then the other piece, I do want to make a comment on, it's interesting to me, we all struggle with who owns this, or who should own this, and how should it be funded, while at the same time we're saying we have to share the data. We have to share the information. At the same time we're saying, let's not build something new. God knows we don't have the money for that. Let's use the existing things, stuff, tools, things that are being developed. And so how do you get to a place where those existing things, stuff, tools are independently or differently owned to a ownership component? So then my question becomes, are we actually looking at more, is there a coordination role that's more missing, and not necessarily who owns it, but who's empowered to be the ultimate coordinator of this, that can then begin distilling down, well, let's define who are the decision makers. What is the information those decision makers need? How do we normally get those data? Are there data gaps? What do we need to build into the existing systems? How do we flip that switch? How do we prioritize the information? And how do we communicate it back to our stakeholders?
And Joseph?
I think anything that gives the FDA greater confidence in the use of the product is the data that we would be supportive of getting. For products under EUA, we want to see those products get approved, and so if this is the opportunity to get additional data that would support that regulatory decision, then that's important to us. And if it's a product that's already approved, we just want to give everybody in the community a greater confidence that the product is safe and effective.
Great, thanks, Joe. Notice again, that's that subtle use of the Joseph coming out aggressively, and then you back off. But now going back to the other three individuals here. Redonna, you just heard what they need, Stacey what they need, John what they need. Can you fulfill any of those needs that they may not even know your capabilities of right now?
Well, what I'm hearing is you need an information highway. You need an infrastructure for data. And our job is not to build that highway, but to see that it is built through our coordination function. And what is so important today is the need to standardize the information transfer, and also to protect for privacy and security, so that information goes from point A to point B, and primarily for three purposes. Number one, to provide care. Number two, for research. And number three? what was number 3? To I forget. Well, just for the purposes of providing that care by folks who are in the early response mechanism, and then later on in the the medical response that's so necessary out there. So our job is to see to it that information highway is built.
Great. Stacey, anything from your perspective?
I think in some regards, it may be an alum's responsibility to help build that information highway, whether it's just specific for medical countermeasures, or is it to provide the information highway with the tools that will apply to medical countermeasures as well, other areas of research as well. So again, looking at ways as to what data is collected, what data is stored. And one of the things that we're struggling with, the idea is, do you store all the data? As our director likened it to, it's like those pictures of your kids. You have boxes and boxes of pictures of your kids, but really, does everybody really want to look at all of those? Or what do you select and actually put into the album? So what information should be stored? How do you preserve that? And how can that information be used? So one of the areas of focus that we're looking at are the FAIR principles. The findable, it's accessible, it's interoperable, I also say integratable, and reusable. So can you collect data once and use it multiple times by different researchers trying to use this? So I think we're looking at across the spectrum of research, but could medical countermeasures, could some other aspect of public health emergencies be used as a test bed or a pilot as NLM goes forward in this area? That might be an interesting proposal to look at it that way. NLM is also involved, actually, although I just met Dr. Fleming, others at NLM have worked closely with ONC in developing standards, both for interoperability as well as in the area of terminology, because that's a big area where you can have miscommunication is how people interpret what is said. So in the terminology area, so we continue to work with them in those areas, and again, might be an area where public health emergencies or medical countermeasures could be used as a test bed.
Great, thank you, Stacey. Redonna, anything from your perspective in the clinical networks?
So, in terms of the CTSA program and their capacity, that is really where you have a tremendous potential for the integration of the delivery of clinical care and research and the collection of data. That's what they do. When you talk about needing people who understand data and the delivery of clinical care as unicorns, that's what I have all across the country.
Right.
So to the extent that we provide funding to academic medical centers to be hubs within their local area, they are also networked, and they have what we refer to as spokes. So there are hospitals, there are federally qualified health centers, there are other points of delivery of care that are working collaboratively with those hubs. And some of the things that we are trying to do right now in terms of taking data and making it interoperable across the network is we're starting with the academic medical centers that we fund, but we want them then to be branching out into all of their hubs. These are places where there are going to be delivery of care. These are places where they are going to be potentially, putting out different types of care, as well as having the potential to be involved in the collection of the data in the research itself. With a protocol that we have for what do you want, what do you need to know, what would you like to know, we can certainly look at how that can be built in and how that can be offered. And what other types of things would it take within a research environment? We have tremendous regulatory capacity with people with regulatory expertise in many of the hubs, and they are starting to function as a network and be a resource to everyone else that might not have that expertise locally. So there's a lot of capacity there. There's entrepreneurship that exists across the CTSA program as well, partnership with industry, understanding what it means to take something through the process of becoming an FDA-approved product, but then also what does it mean and what's needed for monitoring those even after FDA approval has occurred, and how to feed that data and information back into the system to make necessary changes.
Great. Now, have you met Carmen and Greg before?
Not
Okay, after this next station break, we're going to turn to our audience. Okay, now we're going to pretend and all that. Yeah, chat amongst ourselves. So just a heads up to the audience, although you see a red blinking light, Laura gave me the ability to, hold on, I'm getting something over in my, I don't have anything in my ear, but I'm pretending. Gave me the ability to go over. So we are going to, since we come back live again, we're going to go into audience participation mode. So get yourselves ready. Again, identify yourselves, and you have an incredible panel here to discuss things. So you can point questions towards certain individuals or just open questions to the whole panel. So